Thank you and welcome everybody, and particularly welcome to the people viewing online. My name is Dr. Justin Havens. I'll introduce myself a little bit more in a second. But today's topic for myself is really the focus on how sleep interacts with both pain and trauma. The bad news is that there can be a real vicious circle, a downward spiral that can be self-reinforcing. But the good news is it also offers us therapeutic opportunities to treat, to heal and resolve. And we're really going to cover both of those angles today. It's going to be a little bit death by PowerPoint for the first part. There's a few little interactive things that I'm going to do with you, and also a few stories I'm going to tell. And then when we get on to the second part of the presentation, which is all about treatment and EMDR, and following a little bit on from what Mark said first thing about the pain protocol and all of those good things, I'm going to show you a little bit of a clip of an interview I did with a former client of mine, which will just give you a little bit of an experience of how EMDR can be a really helpful treatment approach with phantom limb pain. I'll take questions at the end. It is quite a long slot, an hour and a quarter. But if you've got something that you're a really burning question as we're going through, I think the roving mics will be available. And of course, for those of you that are online, those questions will also get picked up. So it's a warm welcome for me in this slightly warm room in York, but that might just be my heat. So my background, first and foremost, I'm really a clinician. I've had a fairly eclectic career in the field of manufacturing, the military, management consultancy, and then I really found my home as a therapist and quite quickly got into the field of trauma, and quite quickly found out that this rather strange modality called EMDR, eye movement desensitization and reprocessing, which involves these weird eye movements, actually does something really rather useful and transformative in a way that traditional talk therapy, as I'd learned in kind of psychodynamic and person-centered and integrative approaches, didn't really deliver. And as we come on later on in my little talk today, we're going to really see how that mind-body connection that is central, pivotally central to the EMDR approach, is really helpful when it comes to the treatment of pain. After I'd kind of trained and qualified as a therapist and did my EMDR stuff, I then got really interested in the subject of sleep, and particularly traumatic nightmares, which are a really common condition, which we'll see connected with trauma, but also a really unlooked at area. In fact, no one had published an article in the UK on the subject of treating nightmares. It's something like 1974. And that's really where I started and looked at the best approaches for treating nightmares that were around, and my PhD kind of took that and I tried to synthesize that into a more effective approach that was more easily taught, and really trying to take the things that made the approach as effective as possible. In a way, that's my old career stuff coming in as a consultant, where you're looking for the best ways of doing things. Anyway, that culminated in the creation of the dream completion technique, which it's not a brand new innovation. It's building on the shoulders of giants, and also a creation of an animated video, which some of you may have seen, some of you may even have done some of my training. But I'll expand on that later on today, because again, it offers a treatment approach for breaking that pain, trauma, sleep cycle that I'm going to be talking about today. Currently, I work in private practice as an EMDR consultant, which means I supervise and then I also run various training and CPD events as well. And I think we've got probably 2/3 people who may be EMDR therapists, so you may also know me as on the board of EMDR UK. So in terms of the contents for today, first of all, I'm going to really focus on sleep as a foundation for health and the critical importance that it plays alongside, as important as the air we breathe, the water we drink and the food we eat. And then I'm going to explore the basic kind of sleep architecture, and then what happens when that goes wrong, and then how does stress and trauma, and I'm going to use those words a little bit interchangeably today. They exist on a continuum, and the same mechanisms from a neurobiological level kind of work with that. So I'm going to look at the impact of stress and trauma on sleep, and then move into the impact of trauma on pain, and then how those three things all interrelate together. And then we get to the good news, which is recovery and treatment, which is the most important part of it all. So that's what we're talking about today. So sleep is a foundation for health. And we know that newborn babies, not only do they sleep for an awful lot of the day, we've actually found out that they spend a lot of that time dreaming as well. And I'll explain a little bit more about my views on what's going on when we're dreaming in a little bit. But first of all, why sleep a foundation? Well, how long can you survive without air and oxygen? Maybe from the audience, just shout out a number. How many minutes can you survive without air or oxygen? 3, yeah. They call it the rule of 3, actually. 3 minutes of oxygen, 3 days of water, and 3 weeks of food. Actually, it's a little bit longer than that. Generally, it's 3 or 4 minutes and you'll kind of get irreparable brain damage, and 8 minutes you'll die in terms of air. And in terms of water, people could have survived up to about 10 days. And again, with food, maybe 60 days. But those are really at the margins. What about sleep? What do you think? How long do you think the longest? And apologies for those online. You could maybe type in the chat if you wanted to. But how many days do you think you could survive without sleep? Don't be shy. So, well, we know after one night's sleep, we get a bit cranky. 3 or 4 nights, we start hallucinating in quite a severe way. Someone actually did a sleep experiment and they got to 10 days. I don't think it would pass the ethics board these days, but 10 days was kind of the maximum. So we can see actually it's fundamental to our health. And it's really important for us to understand what's going on whilst we sleep. Now, this rather well, it looks like a complex slide, but let me just break it down. So we all sleep in these 90-minute sleep cycles. And the sleep cycles are comprised of 2 parts. The non-REM sleep, which is stages 1 to 4, and then the bit that the dreaming sleep, the rapid eye movement sleep that I'll come on to in a second. So first of all, when we go to sleep, we kind of go through this light sleep and get into an increasingly deeper sleep, which you can see on the graph as we drop down to stage 3 and 4. And you'll also notice that at the beginning of our night's sleep, we tend to do more of that slow wave deep sleep. And if you go into a sleep lab and they wire you up, there are different kind of sleep patterns and brain waves going on with all of this stuff. But the critical thing is that deep sleep is when there's physical restoration. And that becomes critical when we talk about the impact of sleep on pain and the impact of our sleep cycles being disrupted. What then happens is, as the night progresses, we move up from that deep sleep, and then you'll see quite close to waking that little black line, which is called REM sleep, rapid eye movement sleep. And one of the big discoveries they made in the 1950s was that they discovered that rapid eye movement sleep, which you can observe if you're watching someone asleep, because literally their eyelids might be fluttering, and their heart rate is changing, and their perspiration is also changing, and their muscle tone is also changing, that was coincident with dreaming. And that if you woke someone up from their REM sleep, they would normally have something on their mind that they could recall and tell you. So dreaming is a really strange phenomenon. We do 2 hours of it every night. Even for those that say, I don't dream at all, actually, we're all doing 2 hours. And even for people that go, oh, I have these prolific wild dreams every night, they're probably only recalling a very small fraction of that dream period. And it would be a lovely experiment to be able to kind of connect our brains into an HDMI cable and just watch someone's dream for the whole night. And in fact, a very good book on sleep by a chap, an English guy professor who's I think in California, called Matthew Walker. His book's called Why We Sleep, and I really would recommend that. It covers a lot more breadth of sleep than I'm just going to cover here. But he actually described dreaming as a psychotic experience. And in fact, if you kind of went to a psychiatrist and he looked at the video, he looked at your screen of what's going on, he would kind of diagnose you as psychotic. So there's something wild and wonderful going on with dreaming. Good. So the core elements of sleep. So I've already mentioned that slow wave deep sleep, essential for physical restoration. they've done an experiment. Again, I don't know, these are quite old experiments, that when you withhold that deep sleep, it's a little bit like the eat McDonald's for 30 days thing, where your body starts breaking down. What they noticed was that the incidence of pain and the tolerance to pain and everything associated with pain and just their aches in their bodies all went up when that deep sleep goes down. And I'll show later on some of the papers, and it's probably worth saying at this point, as a clinician, I'm kind of a part-time researcher. I'm not an academic. I published one paper, and it's hard work. So I try and talk about some of the neurobiological stuff, and I do have some references, but I wouldn't say this is I'm not a neuroscientist by any stretch of the imagination. I tend to see myself as a pragmatist and a clinician. But yeah, the experiments to withhold deep sleep start having profound impacts on the body. And likewise, REM sleep, which is, as I said, 20 to 25%, 2 hours a night on average of our sleep, is dreaming. And so, and it's dreaming as a form of recovery, memory reconsolidation, if you like. In fact, another way of thinking about sleep is that we sleep to remember, to consolidate our memories. And my daughter's doing A-levels at the moment. So I said, really, if you study before you go to sleep, they've done experiments to show that you're more likely to recall it the next day than if you study in the morning and try and recall it in the afternoon. So we sleep to remember, but we also sleep to forget. And that's the role of dreaming, this memory reconsolidation. And what is it we want to forget? Well, it's the emotionally charged, difficult experiences of the day, the stressful experiences of the day. And again, when we think of stress and trauma, they're really on a continuum. So we might have a difficult session with our boss, or we may have been involved in a much more significant incident, maybe some kind of road accident or crash or whatever it is. And we'll talk more about that in a bit. So the dreaming process, it's our natural way of recovering. And one of the ways I sometimes explain this to clients is that our bodies, if we cut our arm and we clean the wound and we put a dressing on it, a week or two later, take the dressing off, the wound's healed, and it's amazing. If we'd never seen that before, we'd go, wow, that's amazing. And that dreaming is part of our psychological recovery process from trauma, which we know we must have because we all, and this comes on to the evolutionary process, if caveman, or cavewoman for that matter, the first time they got attacked by the saber-toothed tiger, they went into their cave and suffered the effects of trauma and couldn't recover, we never would have evolved as a species. So that psychological healing mechanism, which is very closely aligned for those who are trained in EMDR, I was going to say attachment informed, but the adaptive information processing model, it's all kind of linked to the same thing. And so what's interesting, and again, this is why such profound psychological healing is possible through therapies such as EMDR, where you're encouraging that healing process. EMDR, after all, is only artificial REM sleep. Yeah, does that make sense? The rapid eye movement sleep, our eyes going backwards and forwards, is what EMDR mimics. And so dreaming does enable us to reset, and that's a kind of an important part. I'm not going to talk too much about dream interpretation. I think it's always an interesting one because, of course, we can interpret dreams, and Freud had a lot to say about that, about the unconscious mechanisms that are playing out in our dreams and how it represents things. But Freud also said that sometimes a cigar is just a cigar. So particularly when I'm talking about nightmares, which we'll come on to, that's my key takeaway from that is that we don't really need to interpret it. If someone's being confronted with horrific and scary nightmares that are breaking their sleep up and having all sorts of other effects, we don't really want to interpret. Good. So the 2 hours a night I've already talked about, and yeah, dreams, they're hypervisual and hyperemotional. What's interesting is during REM sleep, there are two other things going on. One, our body is paralyzed, and that's where that can sometimes leak out if we're woken up from our dreams as sleep paralysis, okay? So again, it looks like quite an intelligent design in a way, the dreaming process, because our body's paralyzed so that we don't start acting out in our dreams. And again, of course, some of you may know, particularly if you work with extreme trauma or work with veterans or anything like that, that actually one of the issues can be that there's quite a lot of body movement whilst people are asleep as well. So that's sleep paralysis. The second thing that's going on whilst we're dreaming is that long-term memory is suppressed. And again, it's almost like we want our brain to kind of keep wiping the drive, and that's why we don't remember our dreams. It's really not it's from again an evolutionary perspective. It's not a particularly functional thing to want to remember our dreams, but it is doing something, and that's why we have the phenomenon where some people say they don't dream at all. But at its essence, it's an emotional processing task. Now, thinking about the impact of trauma on sleep, well, before that, we all know that trauma affects the brain. There's been a lot of research, even, MacLean in his triune brain theory of 1952. This is nothing new. And that, again, this is not my area of specialism, if you like, but we know that the amygdala is involved. We know there's a disrupted HPA axis, hyperarousal, and all of those things going on within the brain. And as we're going to go on when we talk more about pain, it's a shared neurobiological mechanism. And in fact, one of the papers I quote later on, chronic stress and pain, they're kind of both sides of the same coin. But the other key thing about how trauma affects the brain is the impact on sleep architecture and the way that impacts on our REM sleep and our awakenings and nightmares. And really a nightmare can be defined as a very disturbing dream that wakes us up. And again, there's a continuum from, waking up maybe at 6 in the morning going, oh, that's a bit unpleasant, through to someone being woken up, almost as their head touches the pillow, everything lights up in their head. And for the most extreme cases, it leads to people drinking massive amounts of alcohol or taking medication, or people I've known that just drive around at night. They just live a weird existence because of the severity of the nightmares that they're experiencing. Now, some of this stuff will all be familiar. I'm just going to think again about the role of dreaming in our recovery. How does our natural recovery from trauma occur? So everyone will have an initial response to trauma, that stress reaction, if you like, where we may think and talk, we may have flashbacks. And I remember reading a book about someone one of these kind of military memoirs about someone that's involved in conflict. And, they get back to their base literally after it, and they close their eyes, and they're literally just seeing the whole thing play in front of their eyes. And it's that emotional processing task that the brain is trying to do. And this should all be over in days and weeks. And in fact, we know that 80–90% of people will recover from a relatively severe traumatic event in 4 to 6 weeks. And that's good. So how is that happening? That's happening through our own psychological recovery mechanism, which is centered on dreaming. And interestingly, the people that don't recover, those are the ones that may end up with a PTSD diagnosis, where PTSD is essentially the arrested recovery from trauma. That process isn't working, and that's why we see that nightmares are so coincident with that, because the nightmares really are the PTSD. They're the unprocessed traumatic memories that are presenting themselves in the mind for healing, but the emotional processing task can't be completed. And so again, we're all familiar with these kind of PTSD symptoms of hyperarousal, avoidance, and intrusions, whether they're visual or body sensation. And that's again when we start morphing over and thinking about pain. And so a nightmare is really a stuck dream. That emotional processing task can't continue. And you may remember from that sleep cycle diagram that REM sleep was quite close to waking. And I also mentioned about intelligent design, sleep paralysis, and not remembering our dreams, suppressing our dreams. I don't know why REM sleep is close to waking, because it actually it's actually a not intelligent design bit, but it's kind of a curiosity why it's so close. Because it does mean that we can be thrown out of our dreams. That extreme emotion that's part of dreaming can actually wake us up. And that's when the dream process gets interrupted, and that's when we don't get the healing task. And that's how we end up with these, not all nightmares are repetitive and the same, but they can, particularly after trauma, they can be. And the brain has almost run out of ideas to help the processing task complete. And so the idea is that that dream material is kind of stuck. The process is interrupted. And how we free that up, I will explain a little bit more at the end. Obviously, EMDR as a solution will always be an option in terms of processing. You treat the trauma, the sleep can get better. And that's typically how things have been. But through my research, I've kind of discovered that that's not always as linear and as straightforward as that, and that actually targeting the nightmares and understanding what's going on with sleep yields better outcomes. So the disturbed sleep cycle, well, it's different for everybody. This represents someone who's kind of awake asleep a lot. And even if they might be in bed, even though they might be in bed for 12 hours, their REM sleep has been disrupted. It's not functional. It's not achieving what it needs to achieve, and they're also not getting the deep sleep. And this is where we see where chronic PTSD and pain definitely intersects that. And there's a little quote in a bit. 50% of people, particularly veterans with complex PTSD, also comorbid with chronic pain. And in terms of the prevalence of nightmares, trauma is not the only cause of nightmares. People have anxiety dreams, people where they may be fearful of what may be coming up in their life or something that's coming up. And as children, it's probably, who here, and again, I'm talking to the people in the room, and online you can say yes if you want to say yes, but hands up if you kind of had a recurring dream from your childhood. You may not have had it for 40 years, but hands up. Yeah, so that's actually quite a common thing. And it's an interesting one, for particularly, well, for all of us, but particularly those who are kind of therapists, and we're all therapists for a reason, where our own journey is normally involved somewhere along the line. And it's always interesting to still reflect a little bit on what that was all about. Anyway, we won't do that navel gazing now, but 2 to 6% of the population at any one time, and they haven't really done good population studies, which is also interesting, may be experiencing at least a weekly occurrence of that disturbing dream. When we go to a clinical population, particularly inpatients, and particularly with the impact of complex trauma, which is very prevalent with serious mental illness, and also pain, not pain, a lot of I was going to say excessive medication, but that's me being judgmental. Just there can be a lot of medication involved at that the rates of nightmares and disturbed sleep are more like 50%, although we don't really know. And then when we go to that PTSD trauma population, again, it does depend upon the life. Many people with PTSD report nightmares being worse, and then they may settle down, but then when stress comes in their life, it kind of flares up again. But up to 90% of people will experience that, which makes complete sense when we think about what's going on with their sleep process being fragmented, and that the trauma is the nightmare. The stuff that's coming up in their head whilst they're asleep is the trauma that their brain is trying to process. That's it. So forgetting pain at this moment, we've still got there's a vicious circle of nightmare, a cycle of nightmares, poor sleep, and stress. And that can manifest itself as being fearful of going to sleep because you know what's coming down the road. And I remember doing part of my researching, I did an intervention with a group of Scottish veterans and one really big, burly kind of ex-infantryman. He decluttered his room, he had the whale music on, he had the lavender on his pillow, but he still said, as soon as my head hits the pillow, I'm back in Northern Ireland and some horrific thing is going on. And so there's a real fear of going to sleep is driven by the nightmares. And then, of course, you've got difficulty staying asleep if you're just involuntarily woken up from this stuff. And then again, at a chronic level, the impact on your day is really severe. Not uncommon for people to spend kind of the first half of the day recovering from the night, and then they're gearing up for the next night. So it can be a real chronic problem. And what we also know is that when stress manifests itself in our lives, that those things become worse, which is possibly one of the reasons why, for example, the delayed onset of PTSD, there's that famous quote of, 14 years, particularly for veterans ago, they kind of don't present for 14 years, and that may be avoidance of treatment, but it's also to do with kind of lifestyle, I think, and the increased stress can then kind of shake the snow globe up. Another interesting thing with regard to sleep is insomnia, which is the most common sleep issue. I would say nightmares are the second most common. But of course, there can be, no one goes to a GP and says, I've got problems with my nightmares. They all go, I've got insomnia. And so insomnia is defined as the inability to get to or maintain sleep. So of course, you can see that nightmares may be a reason for that, but also anxiety may be a reason for that. Pain may be a reason for that. And we'll come on to that again, more of that in a bit. Good. So moving on to talk about the impact of trauma on pain. Well, we've heard quite a lot about this, particularly the adverse childhood experiences, which kind of wire our system up, our neurobiology up, to perhaps be more susceptible to those pain. But it's important that, pain, I quite like this, it's a psychophysiological experience, and it's also a very personal experience. And that's one of the things that makes it really quite hard to work with. And there's a couple of stories here which I think really amplify this. The first one is one I call the nail story, which I read about, which was someone on a building site drove a nail through his boot, and he was in absolute agony. And they needed to take him in an air ambulance. He needed maximum pain relief. They get him to the A&E. They cut his boot off. And what do they find? They find that the nail's gone between his toes. There's no tissue damage. Yeah, phenomenal. But his subjective experience of pain was through the roof. He was on the maximum pain relief. That's the first story, which again, it's kind of, pain is such a funny thing. Not funny in the funny sense of the word, but just strange. The second story is about this young chap, Jamie Hull. I just was literally listening to his audio book, and he was a special forces soldier. He was doing his private pilot's license in Florida, where it's nice and sunny, and he's on his solo flight, and his little light aeroplane basically catches fire. And he's 1,000 feet up, he's got 45 seconds to land it, and he's basically roasted alive in the cockpit. Absolutely horrific. What was interesting is literally as he's trying to land the plane, and he can see his body melting, he says he's not feeling any pain. And then when he lands the plane, well, he doesn't actually land the plane, at 20 feet, he climbs onto the wing, half of his body is in an inferno, and he jumps off. And at that moment, he feels extreme pain. In fact, he kind of says it's a pain that's an indescribable pain. So again, what's going on there? It doesn't sound like it's just an adrenaline thing, but it's almost as if his brain has got to, he's got to land the aeroplane to survive. So it somehow shuts off the pain in a strange way. So those two stories kind of illustrate the difficulties with extreme pain. And we're going to do a little exercise now, a very brief exercise, and everyone online can do the same exercise. What I'd like to do is everybody just close your eyes. Imagine holding a lemon in your hand, and I've got my hand out. You don't have to put your hand out, but you can. And please do this if you're online too. And just with your eyes closed, just sink your teeth, and the audio-visual technicians, you can do this too. Just sink your teeth into that lemon and tell me what you experience. And you can tap it in the chat box online. Or maybe put your hand up if you've got a sense of the yuckiness of the lemon. Hands up if you've got the yuckiness of the lemon. Only a few. Well, or maybe you're being shy. 90% of people say, yeah, they've got that bitter taste, yeah? The question is where's the lemon? There is no lemon. This is just how our system works. And I sometimes use that example when I'm just before doing some kind of relaxation or calm place exercise, which is, again, part of when we use EMDR, part of the things that we do, to explain that's just how our system works. Okay, and for the 10% of people that don't get that sensation, I would then move on to your favorite food and imagine that in front of you, and then people normally notice their mouth salivating. And that's just our body's response to that visual stimuli that's in our imagination, okay? Now, we're not making it up. They're not making up that sensation. It's a real sensation. And so just because it feels real doesn't make it real. And we're right in that kind of that kind of physiological experience that is what pain is. So a lot of words on these slides, but it's really saying the same thing that I said before, that PTSD and chronic pain involve the same neurological kind of mechanisms. The HPA axis, cortisol, the sensitization, the PTSD, the impact of trauma, how it can make us more sensitive to pain due to changes in the central nervous system and what's going on, the amplification of pain and perception through the activation of the amygdala system. Again, when they look at brain regions, the kind of the regions of the brain that are involved in both of those kind of trauma responses and pain are similar. And also at a kind of at a neurotransmitter level. Way outside my comfort zone talking about this stuff, so please don't ask me any questions on that. But essentially, trauma worsens pain because it's disrupting our stress and emotional regulation systems. And you will be getting handouts afterwards, I'm sure, so you don't need to make notes of this. And there are a few references on these next couple of slides. But yeah, chronic pain and chronic stress, two sides of the same coin. And I would argue that they are. And jumping ahead, that's why dealing with the chronic stress is such an important part of pain recovery. And yeah, and that will feature, when we look at integrated pain solutions and different things that we can do, relaxation, emotional regulation stuff to kind of down-regulate the impact of stress is so important. But that stuff's been around ages. The good news is that EMDR offers a more overarching, integrated mind-body solution. We'll come to that in a bit. So yeah, pain and stress and the stress-trauma continuum. As I said, 50% of chronic pain patients meet the criteria of PTSD, particularly veterans and those who survived, severe traumatic situations. And also the fact that they're very self-reinforcing because they're sharing the same neurobiological mechanisms, if you like. The avoidance or the intrusions that come from trauma, will certainly impact on our ability to do some of the things that we need to do to kind of manage and resolve our pain. And that they're also, as the paper at the bottom said, chronic pain and PTSD, the perpetual avoidance cycle. Okay. And when we add sleep into the mix, well, then it gets even worse. Now, in terms of pain, from a pragmatic way of thinking about pain, I tend to I think of event-related pain, which is where the onset of pain is linked to a specific event. So whenever I'm doing, and even someone that presents with what may be seen as a kind of chronic pain condition, I always want to know when the onset of that pain was to see if it does link to a specific event. But very often there can be a clear connection. Someone that was in a car accident that's experiencing whiplash. Now again, many people go, well, that was just the force of the seatbelt, and we need to treat that as we treat, as if they'd broken their arm. But of course, we learn that actually it's much more subtle than that, and that this continuum from psycho to physiological is an unknown quantity. Now, of course, we can't tell everyone we can heal their pain, because that would be clearly wrong. But we should be really open-minded about the extent to which pain can be healed through psychological means, or pain can be reduced, or the perception or the awareness, because that's what we're dealing with, can be reduced. So yeah, and that's also where phantom limb pain comes in. And I'm going to show you a little video of a 3-minute clip of someone I treated with phantom limb pain, which was really interesting. I did that 4 years ago, and I managed to track him down on Friday and get him to speak for a few words about what it was like. So we'll see that. But when we've got event-related pain, as we know, for those that are EMDR therapists, we can target that pain. And the pain protocol, and I'll come back to this in a bit. Obviously, you've heard from Mark this morning I was going to say the pin-up of the pain protocol, but he kind of is, because he's been associated with it for many years. In fact, come on, Mark, what year did you start your work with EMDR and pain? I've got it down as 2000, but am I? 1993 and 94. Wow, there we go. So we've got the man's in the room. So the chronic pain side of things, for me, this is the kind of the pain that persists after tissue repair. And this is a much more complex thing, but also a much more significant thing in many ways, because there's that whole range of diagnoses, fibromyalgia, migraines, IBS, medically unexplained symptoms, where there's a manifestation of a whole complex range of things involving autoimmune issues, attachment wounds. And this is where, again, the complexity increases. But my belief is that we've still got treatment opportunities that are definitely there. And again, that's what I think EMDR offers such a pivotal part in that. So moving on to the pain, sleep, trauma connection. And so we sleep to recover from trauma, and we sleep to recover from pain. But if the trauma and the pain disrupt our sleep, you can see that we've got a problem. And that's really the essence of it, is that there's a complex interconnection and bidirectional relationship between all of those three things. And so, the pain causes the frequent awakenings, the trauma disrupts our REM sleep and causes more frequent awakenings. And when we don't get the sleep, the studies show that pain sensitivity goes up. Pain tolerance goes down, inflammation goes up, and those kind of links to the chronic pain, which again, I'm not, I'm just a very much a lay person on, but they all seem, that whole autoimmune, what's going on at a cellular level, what's going on at a gut level, that all seems very prevalent, present and kind of current today. So, So pain affects our sleep, and as we said, it could be the pain itself that becomes more present in someone's mind, which prevents them getting to sleep. It could be anxiety. It could be the fear of the nightmare. It could be the racing mind that is insomnia. There's so many things that can affect that sleep, and when we lump it all together, it gets worse. And then we've got the nighttime awakenings on top. And it's probably worth leading to fragmented sleep. It's also probably worth mentioning about sleep apnea, which is, again, it seems to have quite a lot of, it's a bit like rapid eye movement, REM sleep behavior disorder. These are kind of quite prevalent and well-diagnosed issues that have been going on a long time. Sleep apnea is these kind of frequent awakenings, and they often prescribe, and stopping breathing, and they often prescribe these kind of CPAP masks to help alleviate that. Likewise, REM sleep behavior disorders, when people are moving about in their dreamings. Well, when you take a trauma-informed approach of both of these, it's not hard to see there's something else going on. That's why it's far better to always try and address the root of the problem. And that's when we get into solutions and treatments. That's why it's that's the key thing, and that we can do symptom treatment, and there's a whole myriad of things we can do without addressing the root of the problem. So poor sleep quality, and we've talked about the key fundamentals, the slow wave sleep, the deep stage 4 sleep, not getting enough of that, and then our REM sleep. It's not really about the quantity of REM sleep, it's the quality of it. Is it achieving what it needs to do? Is the dream processing task being completed? And so we end up in this vicious cycle of worsening pain and sleep. And then throw the trauma in, and then it's, we're distorting the entire structure of sleep. And that, yes, pain medication, yes, physical rehab for the pain, yes, sleep hygiene, yes, CBT for insomnia, and yes, relaxation strategies can help. But my experience is that they're all putting a sticking plaster on the problem. Ironically, actually, relaxation strategy is something I'll talk a little bit more about. One of my earliest experiences of working with a client with pain, and I don't work in pain clinics, I'm just a regular therapist seeing a whole variety of people, not just trauma, but with mental health conditions, was relatively young man. I can't even remember what his trauma was, but we did the calm place exercise. He experienced a change in state internally, because that's what we're doing. It's a bit like the lemon thing. We're getting him to focus on a very calm, relaxing place, as if he's there. His body doesn't know he's sitting with me. His body thinks he's there. And we're encouraging noticing of what you can see, what you can hear, what you can smell, what's going on in your body. And he's, for the first time, this pain that had been sitting with him for years kind of was changing. The subjective nature, I'm sure he would have noticed the subjective nature of that pain before, worse in the mornings or worse in the evenings, but he'd never kind of clicked it. And we did that little exercise, and within 5 minutes, it's like that, it made a dramatic difference. And that was the intervention that actually really helped his pain. And I say that to make sure that we don't forget that one, because we are trying to change perception, we are trying to kind of have a physiological state change, and sometimes relaxation can work really well. Other times, it can be not effective at all, and the client doesn't really connect with it, and they're not really able. And maybe that's with the more kind of chronic, severe conditions that they're connecting with their body is an issue anyway. And in fact, that may be also linked to part of the problem with pain. So we've got this self-perpetuating downward spiral, and which I've really talked about. And the issue is it's far less likely to resolve naturally. We're in this downward spiral, we need to do something. And how do we break that vicious circle? And this is where we move on to treatment approaches. But before I do, one of the things that really surprises me, I had a new patient intake a few weeks ago, and I sent their medication list. I thought it was the history of their medication, but no, it was their medication list. A psychiatrist had actually prescribed an A4 sheet. It was like 15, 20 tablets on it, with everything that you'd expect to see for kind of, SSRIs, but antipsychotics, with pain medication, gabapentin, and with other stuff, and oxygen. It was just, one thing after another, and it just, didn't seem like a way of breaking that cycle. So, and unashamedly, there's a picture of Mark with his picture of his brain, which I nabbed off the internet, but towards recovery, because this is really what we're interested in. It's what I'm interested in, is how can we help treat people? I don't use the word heal anymore, but I think for those of us that practice EMDR, we know that profound healing is possible, and as we've seen it, we're our own evidence base, so to speak. And I know that we've had an introduction to the pain protocol and a little bit about EMDR this morning, but all of the literature over the last 20 years has talked about integrated psychological and physical mind-body approaches as the way to go in terms of treating pain. And of course, EMDR is the ultimate integrated mind-body approach, because right from the get-go, we're focused on imagery, emotions, body sensation, and our beliefs about ourselves and thoughts about ourselves. And I did have a quick look at the EMDR UK, our kind of publications database, and there are 1,969 articles. 53 of those are on pain, from the very first experiments done in 1994, where they were testing, I think, bilateral stimulation and people putting their hand in freezing water and their response to the pain. I don't think you're involved in that, Mark. No, but and I put 2000 onwards, Mark, but he's told us it's 1993. But yeah, I think it's certainly a growing evidence base. And for those that have used EMDR with pain, in fact, maybe, again, hands up in the room if you've used EMDR to specifically treat pain. And again, online, you can say yes if you want to put that online. But yeah, that's a fair few. And so it's really important. Well, I'll come on to some of what I see as my own therapeutic guidelines, but we obviously can't promise anything, and we need to be radically curious about what's going on. But when we think about, pain is a body sensation. It is just a body. It's a body sensation. It's a physiological experience. My simplified version of the pain protocol is, if there's back to that event-related pain, if there's a target associated with the pain, make sure we target that first and we clear everything associated with it. And then we move on and target the pain specifically, whatever that sensation is. And the example I'm going to give of treating phantom limb pain is very much around how radically quick, from what I observed, we were able to resolve that pain. And I'm not sure how much detail that Mark talked about targeting the pain directly, but I just used the straightforward stuff that came from the light stream exercise. With their eyes closed, what metaphorical shape does that pain represent? What color is it? Is it hot or cold, rough or smooth? And go with that and kind of engage with it in that way. That event-related pain, whether it's a whiplash or whether it's a result from an accident, yes, we can target it like that. But when we're into the fibromyalgia or MUS or a whole host of other pain-related conditions, chronic pain conditions, we're likely to see complex trauma. Again, I'd like to say that there's always complex trauma. I don't know whether that's being a bit a little bit binary, whether Mark would agree with that, but I'm sure that's what I would kind of see. But addressing that complex trauma is obviously in the word complex. And that's where the use of EMDR as a therapeutic tool is not straightforward. It's not just a question of, well, let's just slap out the standard protocol and do some work. We need to be really curious about what's going on. And the comment at the bottom here, don't forget the calm place, that really goes back to that example where getting people to really notice their physiological experience and notice how it can change state had a dramatic impact on pain. And I'll never forget that, because for the client, it was a dramatic shift. So these are my kind of guidelines. So I, in my general practice anyway, would see myself as kind of flexible, relational, and attachment informed in the way I use EMDR. And we're really trying to answer the question, how has the person got to be this way? And also, what are the core beliefs that are holding up the pain? And again, I don't think you could be certain on any of this stuff, but self-identity, loving yourself, I've seen some correlations personally and anecdotally with that, and some people experiencing pain and fibromyalgia. And so you're curious about how they've got to be the way they are and how they've got to believe what they've believed about themselves, because that's the thing that becomes almost the scaffolding that's holding someone in a certain place and holding their experience of pain in a certain place. And that, even therapeutically, we might be asking what the pain is saying or what's preventing the pain going. And there's a whole kind of thing there. But expectation management is really important for pain, because we don't know the art of the possible. The whiplash or the chronic pain issue resulting from an accident, we don't know how much of that will resolve if we target it with EMDR. We don't know. So we should always be careful with our clients, but just say, all things, we don't know. All things are possible, though, and opening up people's minds, I think, to the fact that how you perceive something is so important. But it's obviously also really important not to give the sense that this kind of psycho thing where people are just making you saying I'm making it up. I'd never want a client to say that to me. So this was my little example of phantom limb pain. Lovely raw marine chap. He'd had a full leg amputation, and we're going to see a video in a minute. But I was actually his academic mentor for the Open University, and he talked about his phantom limb pain. He had had EMDR previously for the trauma that was involved in how he lost his leg, but that was a long time ago. And I literally saw him, and we did what probably would be a 1-minute intervention. And his experience of phantom limb pain, so he's got a full leg amputation, was my ankle feels like it's where my knee should be. And when he's stressed, tired, or hungover, it's really quite excruciating. And that's what we targeted. And I literally said, just close your eyes, notice that sensation of where your ankle feels like where your knee should be. Just connect with that, open your eyes, and we just did one set. And what do you think he said after the set had finished? So a set of eye movements of 24 passes. What do you think he said after that? Slight rhetorical question. He said the obvious. Anyone? He said, my leg's gone. Which kind of was the bleeding obvious, but he said it in a way that some part of him just realized his leg was gone, some part that didn't know that fully before. And it's this, I think, the whole phantom limb pain, again, it's to do with the map that the body has on his system. And the clue maybe was in the comment, well, my ankle feels where my knee should be. And apparently the surgeons say that there's a kind of a retraction where that sensation kind of naturally moves further up. And all we did with the bilateral stimulation, the eye movements, was accelerate that process and get him to do a new body map. And let's just see what he had to say.
Good. Okay, great, Paul. Well, it's lovely to see you again after a couple of years, and thank you for agreeing to talk to me. I just want to take you back 4 years when we had our little brief session where we did some EMDR to help your phantom limb pain, but maybe just give us a sense of what the phantom limb pain was like before then and how you got to have it, maybe very briefly.
Yeah, good to see you, Justin. Really nice to see you it's been a while. So my story is back in 2008, I was blown up by an improvised explosive device, which led to the losing of my right leg, whole leg. I suffered quite a bit with phantom limb pain due to the traumatic amputation. And this really paid significance into my own mental health and, healing process. I do recall back in 2021, I found it quite inspirational in a way because it changed my thought processes. We did a small session and it helped me understand, and I think more importantly, my brain understand that the mapping had totally changed and the leg itself was no longer there. Therefore, the feeling should no longer be there. And it helped me overcome this understanding of, well, I can't treat something that's not there, but the pain is really my own head.
Yeah, and my recollection was it felt like your ankle was where your knee should have been, and that it was a pain that came on more when you were tired or stressed, and yeah, it was almost like your brain had the wrong map of your body. But we really only did one set of eye movements, and then you kind of looked up and said, "My leg's not there," almost a statement of fact, like my leg's not there, my leg's gone, and then there seemed to be just a shift in that moment that was very strange in a way for you.
Yeah, totally. It was almost like it awakened me. And you're right. I notice my phantom pain more so when I'm exhausted, when I'm tired. I also notice it when I've had a drink as well the following morning.
Yeah.
But it was almost like it opened a door where the connection was now back to understanding about the present moment. I wasn't thinking about my leg being there. I was thinking about the leg is actually gone.
Yeah.
And therefore for quite a while after that, I wasn't concerned with it. I knew that the leg wasn't there, the feeling wasn't there, so I wasn't thinking about it. And it really helped me to process it, I
Yeah.
suppose, in all ways.
But it was also interesting that we couldn't, it's the blinding obvious, your leg's not there, but it's almost like that message got into a kind of a deeper part of your system, maybe. I don't know. Um,
It was, yeah, it was. And I've tried a lot of stuff in the past, like mirror therapy and stuff like that. And it really, it didn't feel right. It didn't sit at home. But when we did the EMDR, it gave me the presence of being where I was at that moment in time. I
yeah.
think that was real. And understanding, more importantly, my mind understanding or my brain understanding that the leg had totally gone.
Mm,
And I was this person now without a leg.
leg. Yeah.
Yeah,
Brilliant.
yeah.
Okay. Thank you very much, Paul. That's superb. Thanks.
Good. So that was Paul, and fascinating. And I'm not normally that kind of ad hoc and cowboyish, but it felt like it was an appropriate intervention to do. But it really was just one set of eye movements and a kind of profound change. And I haven't treated anyone else with phantom limb pain, but it would be really, it feels like that's, that the and I think there are some more recent papers on it, but it seems like, the outcome and effectiveness of EMDR for treating that is, very, very good, I would have thought. Good. So what about sleep though? So of course, if sleep is disrupted by traumatic incidents, we can use EMDR to target the trauma. And of course, the sleep may improve, probably should improve. Interesting from an EMDR perspective, yes, you definitely would think it would be. When you use other treatment approaches for trauma, such as trauma-focused CBT and exposure, actually the results and the impact on sleep aren't so good. And that may be partly perhaps due to the fact that there isn't much of a focus on sleep generally, but I definitely would encourage everyone to identify what's going on with their client's sleep and get a sense of how long and how regular and whether it's disrupted, and are they having, do they notice any dreaming? Are they vivid? If it wakes them up, how easy is it to get back to sleep? And are their dreams based on real events, fictitious or events, or very often an amalgam of the two? And we've also seen obviously how we can target pain directly with EMDR. That's a very useful treatment thing to do. But one of the things that we can do is use this additional intervention called the dream completion technique, which is really an enhanced form of nightmare rescripting in many ways, so that we can actually try and improve sleep and get the sleep architecture working better, get the REM sleep working. But when we get the REM sleep working, we also get some of the deep sleep that can influence pain. But of course, there still is that vicious circle. You could resolve the nightmares, but you'll end up with still people with maybe pain issues that's waking them up. And so then you might need to be integrating some additional stuff that can help with the pain. It's always a difficult one, but what we're trying to do is to break that cycle. So this is the dream completion technique, where we've still got 15 minutes. I'm going to show you a 5-minute video, and this gives a really good explanation. This is a freely available video that's on YouTube. It's translated into several languages, and it's something that you can show to your clients if you want to.
What I'm going to teach you over the next 5 minutes is a simple and practical technique to help solve the problem of nightmares and night terrors, which can include lashing out, shouting, and other sleep disturbances, any of which can lead to an intense fear of going to sleep. It's a technique that helps promote peaceful sleep, doesn't involve dredging up the past, and best of all is something that you can start doing yourself tonight. Since 2013, I've been using this tool to help people from all walks of life, including military veterans with PTSD. And I've seen many times how fixing the nightmares first unlocks a natural healing process that helps to resolve the impact of trauma from the inside out. Here's how it works. Even though we don't always remember our dreams, they happen every night. Under normal circumstances, dreaming acts like overnight therapy. As wacky and weird as they can be, they offer us the chance to work through difficult emotions and process our traumatic experiences from the safety of our beds, so that in the morning, we can start again fresh. Nightmares happen when that natural healing process gets interrupted, either because the brain runs out of new ideas and doesn't know how to move on, or because the dream becomes so intense it wakes us up. If this is happening to you, then I can tell you that you're not alone. Nightmares don't discriminate. They don't care how tough you are, smart you are, or what you do for a living. Around 1 in 20 people get them, and if you've experienced trauma, it's more like 9 out of 10, with the nightmare often feeling like a replay of the original trauma. The first thing I want you to remember is that you have power over your dreams and the kind of sleep you experience. Even if your nightmare is about something from real life, however awful, that event is in the past. What's happening in your sleep is just a dream. Most importantly, it's your dream. You're in charge. So it's okay for you to decide to change what happens, and there is nothing to fear in your dream. I want you to think about your most recent nightmare or your last bad sleep experience. You don't have to analyze what it means or relive the whole thing. Just think about the point when you woke up and what you'd want to have happen next in the dream that feels good. Take some time on this. What we are looking for is a new direction for the dream to take. Something brief and simple and just as powerful as the nightmare. Something to kickstart the dream, to remind your mind that it's okay to stay asleep through any dream. Or, if you don't remember your nightmares, something you could be doing that would help get rid of the unpleasant feeling or sensation you wake up with, so that all-important healing process can complete its work. Here is the second thing I want you to remember. Whilst they may feel very real to you, dreams don't follow the same rules as real life. So, your imagined solution doesn't need to be moral or peaceful, or something that could happen in reality. Perhaps your solution might be a way to gain complete power and control within the context of the dream, or it can be something that seems totally unrelated. It can violate the laws of physics, be surreal, or feature fictional characters. It can be violent, it can be pure fantasy, or even a little bit silly. You don't have to defend it or explain it to anyone, and if you find that it doesn't work for you right away, don't give up, because you can replace it the next night with something that will. Whatever new idea you decide to put on your dream shelf, it should ring true to you at a gut level, as something positive, something that is at least as strong as the worst part of your nightmare. Like a powerful memory from your past. The stronger the feeling, the more it will propel your idea into the dream. Write down your solution, and just before you go to sleep, read it, imagine it, and think, this is what I want to happen in my dream. It sounds simple, but there is a lot of evidence to show that it works, and that by starting tonight, you could see immediate improvements, or even have the best night's sleep you've had in a long, long time.
Good. So as an intervention, that's something I use very early on. If within the first or second session I get a sense that there's disturbing dreams or nightmares, whether it's linked with trauma, pain, or whatever, this is an intervention that you can use. And typically you might spend 15 minutes delivering the intervention. And the idea is that the person goes away, the client goes away with a new dream idea that they're going to put on the dream shelf that night. In fact, you're going to create it, co-create it with them in the room, and so that you've almost activated that intervention. You've always activated that new dream idea, so that when they go to sleep, They're just reminding themselves that this is what I want to dream about tonight. And all we're just encouraging them to kind of almost drop a new idea into their bucket of dream material that's going to push it in a different direction. We're almost trying to bend the dream in a different direction. One of the clever things is that even people with sleep issues, that may have been going 20, 30, 40 years. In fact, I think I had a 90-year-old gentleman who was at the Battle of Suez or the invasion of Suez, and he still had nightmares from that. And he sold it overnight, and it really is possible. And it's that same thing that we can see where we create the conditions for healing and stuff happens. One of the questions people sometimes say, well, how can I think about something now as I'm talking to you, and how can that get into my dream? And the thing I always say is that ideas get into dreams on the back of emotion, right? So if you watched a horror film, you wouldn't be surprised to dream and have a nightmare about it because it's emotionally, it's highly emotional. I don't recommend watching horror films particularly. I don't know why some people seem to be really fascinated by them. But conversely, if we want to get our new dream idea or their new dream idea into the dream, that's why we want to really elevate the primacy of how it feels. So very often with PTSD memories where people feel powerless and out of control, just the thought, well, what would it look like for you to be powerful? And it doesn't need to be related to the context of the dream or the story or the narrative or any of it, but what does it look like for you to be powerful? And if it's flying through the sky as Superwoman or whatever, Superman, Wonder Woman, that's fine. And in a way that we use the calm place to kind of beef up, so with your eyes closed, how does that feel to be flying through the sky? Or how does it feel that you're 30 foot tall and the perpetrator's a little kind of thing that you're squashing? You're trying to get a felt sense of that. And it's really that carries the idea into the dream. So, if someone was having dreams about being caught in an avalanche, and that may be because they were caught in an avalanche, or maybe they were in a ski resort where someone died in an avalanche or had a close shave, it doesn't actually matter. The emotional processing task is what the brain is trying to do. And it may get that they're stuck and they always wake up at the point where they're being buried alive in the snow and they can't breathe and they're going to die. That would be a typical point where they wake up. So the question is, what do you want to happen next that feels good? And it may be that if they like running, they could imagine winning a running race or doing some other thing where they're powerful and essentially victorious. And it's that makes it work. As part of my PhD, we've done some research on that. Now, the interesting thing is not only are we improving our sleep, and by virtue of that, the architecture of our REM sleep and our deep sleep, which can impact on pain, but also we're cleaning up the trauma and therefore our PTSD symptoms may reduce. So again, it's a very helpful stabilization. I think my research showed that on average, trauma symptoms reduced by about 50% for those that were able to successfully use the technique. So winding up and moving on to questions, both online and in the room, it's really imperative when we start focusing on sleep that we break the trauma, pain, sleep cycle. EMDR is an excellent tool for doing that, for providing that integrated approach, but we need to roll in other interventions which are also highly effective. And we don't want to ignore sleep because we can now see its critical role in the treatment of pain. And so I'd encourage you to be flexible, to experiment, but to have hope that actually we can do a lot better with pain than many people who experience chronic pain or pain of whatever type are currently faced with. So thank you. I think I've got to the end. We've got time. We've got 10 minutes for some questions, or 7 minutes for some questions. Maybe we could start with some online questions. If you could speak up. Oh, nice and loud, because I'm slightly slow. Thank you.
Hello.
Perfect.
It is on. That was wonderful. Thank you very much. One of the online questions, is there a child's version of the dream completion intervention?
Yeah, good question. So an Australian lady who works with children actually wrote a great book called The Dream Director, which is kind of that video, but is a picture book, encouraging children to be the director of their dreams and to kind of yell cut and then put their next, kind of load up their next scene of the movie. So for very young children, I recommend that. Kristin Tappel, I think is her name. I wrote the foreword for her book. But for teenagers, this is absolutely fine. And children have got a very creative and active imagination. So they might, and the nightmare of the monsters in the cupboard may yield to, they really think the monsters are in the cupboard. And so they're very adept at, well, yeah, then I can blast them. It all works well. We want it all to go back into the washing machine of sleep, particularly with children. Good.
Wonderful. Laura says, are there any contraindications? I'm aware the usual sleep hygiene approaches, for example, are not helpful for people with ADHD.
Are we talking about the dream completion technique, do you think? Contraindications on
Yes.
using that or in...
I think so.
No, I think so. I think the key thing for success is, again, it's like all of these things, we really need to understand where the client is and what is their primary way of seeing the world. And I'm even using the word see. So they may be more visual. It may be harder for someone with the diagnosis of ASD to experience the emotion. So you might kind of veer it more to body sensation. So there are no contraindications. Many of the things, there are no contraindications. I mean, I guess the other issue would be about, and I haven't really addressed this too much, is the impact of pain medication on EMDR processing and the impact on pain medication on how successful the dream completion technique will be about getting people kind of restored to their natural sleep cycle. So my own view, and I'm not a prescriber and I'm not a psychiatrist, is medications tend to be very much a kind of hammer to crack a nut. We don't know the effects. We know probably that, well, sleep medication and alcohol, they kind of flatline you through the sleep cycle. So you might be asleep, but you're not getting the deep restorative healing for your pain, and you're not getting the REM sleep for your psychological healing. So I tend to, my tendency would for people to go natural, be natural, but you always have to work with the prescriber and whatever's going on. Good. Any questions in the room? I'm more than happy to take any questions. We've still got a few minutes, I think. Good. Hopefully here we go, down here. There's a microphone coming.
I've got a client who hallucinates just before he goes to sleep.
Hallucinates.
So
Yeah.
he sees spiders on the wall. That's not linked to his trauma, but has developed since a trauma. He had a workplace accident where it was a crush injury.
Uh-huh.
Would the dream completion technique work? Because I'm wondering if he actually is falling asleep and that is a dream.
Yes.
So would the dream completion technique work in that situation?
Well, the key thing with a lot of these things is to try it. So I think your hypothesis that the client who's seeing spiders he thinks he's seeing spiders in the room, but he's probably in that, it's called the hypnagogic stage between awake and asleep. And it's the same thing as this kind of sleep paralysis where people wake up feeling they think they wake up feeling paralyzed and they're seeing someone, or they're seeing, very common when people talk about some of the old literature of like the demon sitting on your chest and I'm paralyzed. But of course, you wouldn't want to enter into a debate about, well, is that real or is it not real? Are you hallucinating, you're asleep, you're dreaming? I would just kind of say, well, what do you want to do to get rid of the spiders? Is there a sleep paralysis argument? Does he experience sleep paralysis with it? No.
No.
Okay, so I would just kind of say, how do you want to get rid of the spiders? I mean, a flashback, very common, obviously with trauma, is an image from the past that's not real in that moment, but it feels real. The spiders feel real. Back to the lemon thing. I'd probably do the lemon test. Just because it feels real doesn't make it real. And then, what do you want to do to get rid of the spiders? And, be creative. I'd probably get a blowtorch out, but it's not very PC.
Thank you.
Hitting the spiders. Okay, any other questions before we finish? Anything else online? Mark's got a question. Hopefully he's not going to pin me down.
First of all, I want to say thank you, Justin.
Oh, hang on a second, Bob.
Sorry, Justin. Just want to say thank you because I actually did this or gave it to a police officer I've been treating for some years with chronic PTSD, and always he gets the nightmares and sometimes he has to sleep in another bed because he's thrashing around in bed.
Yeah.
And he really found it helpful. So thank you.
Did it have an impact on his pain? That'd be an interesting one. I mean, you're obviously treating
Actually,
his
no,
pain.
it was just for PTSD.
But did he have a pain?
No, he doesn't
There wasn't a
have
pain thing going on either. Okay, no, that's okay. Because I think, I haven't done enough work on the impact of this on pain. I'm not really a pain specialist. I was quite flattered that Jane asked me to speak. So I've had to kind of bone up on the pain side of things. But I think there's so much more in pain. And when we look at the costs to the health system on pain, it's phenomenal. And so I think this is a really important area. But thank you for that.
I had one other question.
Oh,
Do
yeah,
you have anyone it doesn't work with? Obviously, that nothing works for everybody. And what would be your sense about why and who it doesn't work with?
For dream completion?
Dream completion, yeah.
Well, we talked about the impact of medication and alcohol. Those can be things that can impact the outcome. It's interesting, the most skeptical, when I did my early research with veterans, the most skeptical people often seem to get the best results. People who are more creative, but it's also then about how you're kind of selling the concept to them, because it can appear incredibly easy. It's like, well, I've had this for 20 years. You telling me that I think of this and it's going to happen? And, well, yeah, I am. And, well, why haven't I thought of this before? Well, you haven't thought of this before. So, yeah, I don't think there's any fixed answers to Mark's question, but I think it's interesting you can always be surprised. The thing that I love about it the most, and when I'm doing my webinars, and I probably finish on that. Yeah, so, I do a 3-hour webinar for therapists, teaching the dream completion technique, teaching people how to teach it to clients. One of the things I always encourage is the co-creation of the idea with the client. And I don't know if I love the idea that sometimes ideas and images can pop into my head. And of course, we're always tentative with how we share that, but it's a co-creation. And some clients can get really quite animated and excited. And when I do my webinar, I always do live demonstrations, which always puts me on the spot a bit, but it's really interesting you're wanting people to make these internal connections with something that really resonates and has got some real emotional oomph to it. The other thing I've got, which is relatively recent over the last 6 months, is a self-help program on stopnightmares.org, which essentially it's a collection of 6 videos, including the animation and the workbook. And I currently sell that. It's only £25 for kind of lifetime access. So that can be a good option for people that just want to do it on their own. But if you're a therapist, I'd encourage you to just learn it and teach it to your clients, because it can produce really incredible results quite quickly. Doesn't always work for everyone. As we know, as Mark said, not everything works for everyone. But we've got some really powerful tools now, and we're only making use of our